X-rays in orthopedics. Lots of X-rays. I have selected few of them which are practically feasible to remember. One of them is von Rosen view, which is for developmental dysplasia of hip, DDH. DDH has a shallow acetabulum. So normally the head articulates with the acetabulum. If it is shallow, the head will dislocate, unstable. Developmental dysplasia of hip, von Rosen view is done for it. When you have cervicothoracic junction, it is the head which overlaps it. So what you do, you position yourself like a swimmer so that the head of humerus goes away. You can take a beam to the cervicothoracic junction called as swimmer's view. The acetabulum is a 3D structure. You rotate the pelvis in different direction to have a look at different areas, called as the Judet view. Judet name is associated with acetabular classifications, acetabular views, acetabular surgical approaches. And then that's how it will show you different parts of the pelvis. The upper part of cervical vertebra cannot be appreciated on AP view because of the dental area occluding it, blocking it. So what you do, open your mouth, pass a beam through the mouth, transoral, click for the odontoid, O, So O for open mouth, O for odontoid. You can see this right in the center. Very, very clearly visible, right in the center. Open mouth, odontoid. Then upper end of femur with pubic rami makes an arch called as Shenton's arch. With a dislocation or a fracture anywhere, this Shenton's arch is broken. Shenton's arch, Judet view, two most important X-rays. When we go to radiology further, X-rays is usually the first tool. We'll show you the bone, soft tissue planes. Will not show you the cartilage. But if you want to go to specialized investigation, CT scan will show you cortex and calcification. So C for cortex, C for calcification, C for CT scan. Similarly, M for MRI, M for marrow. Majority of the diseases are in the marrow, so MRI in orthopedics is a gold investigation, very valuable. Then in between, when you look in between the two vertebrae, you will be able to see the disc. The disc is made of cartilage. Cartilage is not seen on X-ray, is not seen on CT scan, is picked up on MRI. And then look at the neural tissue here. Soft tissue, brain, spinal cord, ligaments, tendons, nerves, vessel, muscle, fascia, fat. They are soft tissues. Picked up on MRI again. MRI, CT, they will give you different cuts. The sagittal view, the coronal section, transverse section, and ask you to pick up. For example, one of the commonest MRI of the knee, they show you a sagittal view. They actually want you to answer that posterior cruciate ligament is the most posterior element, and ACL and goes anterior. Mind you, both start posteriorly on femur, but it's the tibia that decides the name. This is your patella, ACL, very well seen here, restricts the hyperextension and internotation, whereas PCL, it restricts external rotation. This is classical. These are sagittal views, you must remember them. CT scan is white, calcification cortex. MRI is darker. MRI has two images, T1, T2. T1 has one in it. First prof subject, anatomy. T1 will show me anatomy. T2, second prof subject, pathology. it will show me the disease. Water, that is CSF, synovial fluid, traumatic edema, inflammatory edema. It looks white on T2. So water, white on T2. Classical. Remember that. How do you remember? W, W. So 2 times W, so T2. MRI T1 image anatomy, T2 pathology. Stir image called as short tau inversion recovery, because fat is hyper intense on both T1 and T2, so you need to suppress it to see the lesion sometime. And then sometimes you have a diffusion images, which is very useful in acute brain injuries and also to differentiate benign from the malignant diseases. Benign, in the diffusion scheme, there is no obstruction. Malignant, there is. Remember, any inflammation on MRI will show you marrow edema. So if I jump down from one step, it's a normal force on a normal bone. When I jump down from a table multiple times, it's abnormal force on a normal bone. Abnormal force causes a stress on the bone, called as a stress fracture, in which you have marrow swelling, marrow edema. To see marrow, you have MRI. So when you have stress fractures, MRI. When you want to scan the whole body, bone scan. B for bone scan, B for bone scan, B for plastic activity. So wherever there is a fracture, there is an osteoblast response. Bone scan will be positive. Infection, bone will be damaged, osteoblast will repair, bone scan positive. If there is a tumor like prostate, which is osteoblastic metastasis, bone scan will be positive. B for bone scan, B for plastic activity. That's how hyperintense area look like. So when they talk about stress fracture, overall is MRI, unilateral is MRI, but if they mention bilateral or multiple, bone scan. Why do you choose MRI for unilateral or overall? Because MRI is as sensitive as bone scan, with providing greater anatomical detail and specificity. That is why MRI is number 1 for stress fractures. I told you that if you have metastasis coming from prostate, osteoblastic, bone scan can pick it up. But is bone scan good investigation for metastasis? No. We have something better, PET scan. You give deoxyglucose to the patient, label it with fluorine, called as fluorodeoxyglucose. Whenever any cell has anaerobic metabolism, also like tumor cell, it will pick up and show radioactivity like here. So if they show you about metastasis single, MRI, because in orthopedics, nothing compares to MRI. But multiple, PET scan. Multiple osteoblastic, they have to mention bone scan. Because bone scan can pick up osteoblastic mets where PET scan is quiet. Look at this image of a young child. What crops to your mind? Swollen, shiny skin. Let me give you history. 6-year-old child. Pain over the leg. Swelling over the tibia. Fever. What comes to your mind? Infection? Isn't it? No. When you have pain, fever and swelling, think about 2. One is tumors, one is infection. You know, both tumor and infection can be seen in metaphysis. Further confuses. Both can present same pain, fever, swelling. Further confusing. In fact, one tumor which is very common mimics osteomyelitis Ewing's. Second, osteo. Ewing's and osteosarcoma, they mimic osteomyelitis. Both are malignant. In fact, Ewing's is diaphyseal, but overall, tumors are usually metaphyseal, like osteosarcoma. How will you differentiate tumors and infection? They are differentiated by tissue diagnosis. Open the area, take out the tissue, divide into 2 parts, send one for culture. If it's infection, it will grow. If it's a tumor, on histopath, the second part will show the characteristic cell. So send for culture and histopath, both called as a golden rule, culture all biopsies, biopsy all culture. So when you have Radiological investigations for infection, MRI will show the changes first. Then bone scan, X-ray takes 24 hours. Whereas tumors, MRI is very good. Except one tumor which is in the cortex, osteoid osteoma. And because it's in the cortex, CT is very good for it. So infection or tumors, do a tissue diagnosis, culture for infection, histopathology for tumor. So the first logical investigation, X-ray. The next investigation or radiological investigation, MRI. But the best gold standard, tissue. B for best, B for biopsy. Remember this controversial point. Developmental dysplasia of hip, investigation of choice is MRI. Screening tool, ultrasound. There is an alpha angle which decreases on ultrasound and there is a beta angle which increases. So alpha decreases, A, D, remember that. Whenever you talk about tissue diagnosis, bone biopsy is of paramount importance. Always done after clinico-radiological evaluation. Examine, do X-ray, MRI, then biopsy. Give a longitudinal incision along the axis. Avoid the neurovascular status, go through the muscle. Make a round or an oval window to prevent any stress risers in a square window. Take a biopsy from the periphery because the center will have necrosis. Take from multiple sites. Whatever tissue you have, send it for cultures, send it for histopatha, and if required, send it for PCR or serology for mycobacterium. When you have a joint swelling, largest joint, knee joint, get an X-ray, do an MRI, aspirate. If there is an effusion, if you think it's infection, whatever aspirate is there, evaluate it, culture it. And if it's a traumatic situation, do an arthroscopy. Whatever aspiration you do, it's always done ultrasonography. So aspiration is ultrasound guided. So joint swellings, do an X-ray, MRI, effusion, aspiration, which should be by ultrasounds, or trauma, arthroscopy. Stress fractures, we spoke about it. One of the commonest stress fractures in the human body is a march fracture, which involves the second metatarsal neck more than the third. It's also called as a shin splint if it involves the tibia. It will have repeated episodes of walking, military recourse or jogging. In upper limb, olecranon, and in the spine, an area called as pars interarticularis involves the L5 area. Treatment, strict rest and cast. Cast prefer over the rest. Every bone has a covering called as periosteum. Periosteum has a fibrous layer which only holds it. But the functional layer, the cellular layer, is the cambium layer. C for cambium, C for cellular. Whenever a bone fractures, cellular layer produces cells and nutrients for it to unite. If this layer is weak, then the bone will not unite. Example, neck of femur. Second, if there is any infection or malignancy irritating the bone, the cambium layer will throw a response called as periosteal reaction. What is it? Announcement that look, bone is getting destroyed. More the damage, more the periosteal reaction. And then if you have less damage, less the periosteal reaction. Narrow zone, benign disease. Wide zone, more periosteal reaction, malignant disease. And then the last point, you have tumors coming from periosteum like osteochondroma, osteosarcoma. When you are treating such tumors, remove the periosteum. Otherwise, if the source is left, they will come out. Give you an example. There's a tap, there's a bucket. Tap is on, water is coming. Fills the bucket. Your mother says, keep the bucket empty. Option 1, keep throwing the water. Option 2, close the tap, throw the water. What is better? Closing the tap. Because you're cleaning the source. That is why in these tumors which come from periosteum, when you remove them, remove the tumor along with the periosteum, called as extra periosteal resection. Means removal along with periosteum. This is what I spoke about, narrow zone, wide zone. Single layer, solid periosteal reaction. Benign diseases, infections. Multiple layers, lamellated. Multiple rays coming out, sun ray. Triangular piece of bone underneath the periosteum, Codman's triangle. So when you look at a single periosteum elevation seen in osteomyelitis, day 7 to day 10. So loss of soft tissue plane occurs after 24 hours. Earlier change, then periosteal reaction which comes in the second week. Wide zone, 3 types. Triangular piece underneath, Codman's triangle. Multiple layers like the peels of an onion peel, but then you have the classical sun ray appearance. So when you have sun ray appearance, think about any malignant lesion, usually osteosarcoma. When you have a triangular piece of bone underneath, any malignant lesion, usually osteosarcoma. When you have multiple layers, that will give you a hazy feeling, the cortex. Onion peel appearance, any malignant bone tumor, usually Ewing sarcoma. Remember one golden principle: tissues are diagnostic, radiology suggestive. If they ask you, onion peel reaction is diagnostic of, diagnostic is biopsy. None of the above. People end up marking Ewing's or malignant bone tumor. That should not be the case. Remember, tissue is diagnostic, radiology is suggestive. So let's look at some classical radiological features that should come to your mind. Sun ray appearance or the Codman's triangle, osteosarcoma, but can be seen in any malignant bone tumor. Onion peel appearance, Ewing sarcoma, but can be seen in any malignant bone tumors. Soap bubble appearance, seen in giant cell tumor. Multiple tuberculi inside the tumor, also in adamantine bone. Patchy calcification, places where calcification is there. Cartilaginous tumor like chondrosarcoma and chondroblastoma. And homogeneous osteosarcoma. If they don't mention the word patchy or homogeneous, follow the order: chondrosarcoma, chondroblastoma, osteogenic, because cartilaginous tumors, they calcify. This is patchy or mottled calcification. This is again dense calcification of cartilaginous tumor. This is uniform homogeneous of osteosarcoma. And as long as people read science and ortho is a part of it, they have to remember lower end radius, tumor going right till the joint is the giant cell tumor. Giant cell goes till the joint. Giant till the joint. So GCT is the only tumor known to man which can involve the cartilage. So remember this classical image: soap bubble appearance. Sun ray appearance is a periosteal reaction. It's a controversial point. Do remember. These wide zones are also called as aggressive lesions, and narrow zones are non-aggressive lesion, solid, thin, thick or irregular reactions.